All right, great. Well, welcome. Yeah, thank you. Good to see you. Welcome, everybody. I think we'll go ahead and get started. We still have a few people coming in. And we've got a lot to talk about today, a lot of good information to present. So thank you all for joining. And we will just go ahead and hopefully everybody can see the slides. And if you can't, don't worry about it. We're going to send these out as a packet right after our presentation. All right, so we're going to talk about modeling and projections. This has become germane once again, just because we're really on the cusp of a statewide surge and a countrywide surge that we will talk more in depth about. There was a healthcare order that's quite significant that came out in July 26th, so we will go through the details of what that requires. There's also new masking guidance from CDPH and CDC. And then, I think the theme of today will be surge planning and concerns, and we'll certainly share the planning and progress that we're doing, but we want to hear from all of you about what your concerns and goals are so that we can help support all of you. All righty, so, we'll start with this very simple statistic. This is called the R naught or the R effective. This basically is a marker for transmission of really any infectious disease. And basically the way that I understand it, not being an epidemiologist, is that, for every person who's infected, the R effective is the number of people that they will go on to infect. When the R is less than 1, that's good. It means that the disease is not finding new victims and it will eventually burn itself out, especially if it's very, very, very far below 1. So as you can see, we were below 1 on these projections for quite a while through the spring months. And that's kind of why we reopened things. I mean, everything was looking good. Our numbers were coming down. However, the R has now crossed that magic threshold of 1. And it actually went from 1.28 up to 1.45. So in our region, which is shown on the map there, the R is now well above 1.28. And it's basically at 1.45, meaning that spread is not only going to occur, but that it's accelerating. And that's what we're talking about when we say that there's a surge coming. More projections here, and I'm going to just batter you with statistics that I hardly understand, so please forgive me. But these are basically just what the state is modeling. We've done some local modeling as well, and Dr. Kumar, who's our senior epidemiologist, is helping us find really important trends that we're keeping track of. But basically, this is what is projected to happen. As you can see, this was done a couple of days ago, but basically all the case counts are going to go up. And these are all these different lines are different models and different assumptions. But everyone is expecting case counts to go up. Statewide hospital projections predict approximately doubling the number of COVID patients between now and sometime in late August to early September. Meaning that, statewide will basically have up to 10,000 hospitalized patients and up to 1,500 ICU cases, the way things are going. Closer to home, this is what our numbers are looking like. It's really hard to see, but you can see kind of an uptick right at the very end of this graph, which is our total case count. I think what's more important is that our positivity rate is going up. So the way we think about the report card for the county is, when positivity rate goes up, that usually leads to increased case counts. When increased case counts happen, that usually leads to increased hospitalizations. And then a few weeks later, an increase in the number of deaths. That has been borne out for the last 2 surges, the one that happened last summer and the one that happened last winter. And that's exactly what we are starting to see now, is that our positivity has gone way up and now our case counts are going up as well. In terms of Fresno projections, here's what's expected to happen. Again, a slope. We're hoping it's just as gentle as possible. Everyone remembers that phrase, flattening the curve. Well, this is what we're talking about is, we need to be doing everything we can to help flatten this curve so that it doesn't flatten us. That was for cases, and this is for hospitalizations. Again, the curve is expected to go up. Knowing that predictions are predictions, I wouldn't put too much stock in the actual number, but just to let you know that, between now and mid-September, we're really going to get busier and busier with the burden of COVID patients that we're seeing in our area hospitals. Statewide, this is a very telling slide. because what they've done is divided out people that are hospitalized and really cases as well between the vaccinated and the unvaccinated. So, I think this chapter of the pandemic can be called the pandemic of the unvaccinated, because that's what we're starting to see, is that unvaccinated individuals are definitely getting hospitalized at much higher rates than vaccinated individuals. And that's really who's driving the cases as well. So that's the solid line that you see at the top. On the left chart, it's cases. On the right chart, it's hospitalizations. And you can see that the solid line of the unvaccinated cases and hospitalizations is magnitudes higher, or one magnitude higher than the vaccinated individuals. And that's really what our hospitals are telling us, is that, a rough estimate is that 10% of their inpatient caseload is vaccinated individuals versus 90% who are unvaccinated. There's a rapid rise in the Delta variant, and that's probably what's driving this surge this time. The Delta variant is known to be more contagious. We know that it causes more severe illness, and now it's being detected more and more in asymptomatic vaccinated people, at least when they swab their noses. So there's a thought that when you're vaccinated, that perhaps the antibody response takes a little while to really fight this virus. And so that gives the virus a little bit of time to multiply inside your nose, but then it doesn't get any further than your nose. And so that's why these people, even though they have legitimate viral infection and lots of it, their viral loads are probably as high inside their nose as people that are not vaccinated. However, the immune response kicks in and then basically keeps that viral load from affecting the lungs and other organs, et cetera, et cetera. So that's kind of the current theory. Obviously, it's changing very quickly. This is a very dynamic picture, but that's what people think is happening, is that, the Delta variant has been able to find vaccinated victims. However, the vaccinated victims, their immune system kicks in. And then basically, even though they pop positive on the COVID testing, they don't really act that ill. And so that's why they're not being hospitalized at equal rates compared to the unvaccinated. So it's kind of an interesting thing to think about that we really didn't have to think about before we had vaccines and before we had the Delta variant. But now with the onset of the Delta variant and the presence of a huge number of vaccinated people, fortunately, we are seeing some of these different risk categories emerge that we didn't see before. The Delta variant is characterized by this line on the very right. And really that line is just taking off. And it's probably higher even than before when this slide was made. They've looked at all the variants, and really, every variant has its day and then it kind of goes away. And that's basically what you see here: alpha, beta, gamma. They basically, and the different colors here are the different regions of California. And you can see alpha kind of peaked and then it went down, beta kind of peaked and then went down. Right now, delta is peaking. We don't know where the top is going to be, but that's what seems to be driving this recent surge of cases. And so that's just kind of interesting that, the other variants are being kind of crowded out. And that's basically because Delta is much more successful and it's able to compete and crowd out these other variants. Here's some interesting data from our region, and every county is now seeing an increased rate of hospitalized patients, some more than others, but basically, some counties are actually smaller than Fresno, so that's kind of what determines some of these numbers. But you could sort of see here is that from week to week, the blue week is from July 13th to the 19th, and the orange week is the week that followed. From week to week, every county is reporting an increase in the number of hospitalized cases. The reason that that's important is because we do act like a region, especially with our tertiary care hospitals and some of our transfer protocols and things like that, so that whenever one county is strained, for example, and needs a lot of resources, that actually strains the whole regional system. So we do act like a regional system, especially in times of surge, whenever our capacity limits are really stretched. And so it's really important for us to have this situational awareness that this is not just something that's affecting one county or one part of the state. This is affecting every part of the state and really every county here in the Central Valley. So these are some of the areas of concern. COVID cases are rising very quickly, especially among the non-vaccinated. Hospitalized cases will likely rise. And I think that that's already happening. I made this slide last week, and some of these slides are actually already either prescient or old, depending on how nice you want to be. But basically, vaccine breakthrough cases remain a small fraction overall. we're actually seeing cases in summer camps and daycares. The reason that I think that that's an important piece to be mindful of is because it's really a preview of what's to come when schools start to reopen and when school sports restart. So I really think that in August, whenever schools reopen in full, we're going to see a lot more school outbreaks. I'm just afraid that, it's just a really bad time for schools to be reopening, but it is what it is. And this Delta variant that's surging right now is really going to complicate how schools reopen. We're really trying to message with our school partners as best as possible, and obviously with our community at large, that we just have to be super careful to prepare for school reopenings. And then when schools are reopened, we really just need to be doing everything we can to keep kids in school by making sure that we don't have unchecked transmission throughout those campuses. It's going to be a real challenge. The vaccination demand has already been declining. It's been declining, and we really aren't at goal, which is really disappointing. And that's working against us during this surge. Our early warning signals are suboptimal. We're not really doing the testing of higher risk populations. And that was really one of the reasons why at the federal level, they really just signaled that we need to be doing testing of healthcare populations, especially those that are higher risk, meaning that they're not vaccinated. And that's what prompted this very quick release of the state health officer order, which I will talk about in the next few slides. We're also hampered by the fact that we don't have good variant sequencing. I mean, right now, what I'm telling people is that just assume it's Delta. I know that that's not a very scientific statement to make, but really in light of the fact that it takes 3 weeks to come back, and Delta variant is surging so dominantly compared to other variants, I think it's a safe bet to make, is that just assume it's Delta. It doesn't really change how we treat the patients, but it does explain the fact that, for every patient that you catch that has COVID, they're really infectious. The statistics really suggest that, the copies of the Delta variant of the virus are 1,000-fold higher than the copies of the other like alpha, beta variants of the virus. So it just goes to show you just how contagious this variant is. And I think it explains why we're seeing the high numbers that we're seeing, the increasing numbers that we're seeing. Outbreaks in high-risk settings. Unfortunately, we've gone through this before. We've had several iterations of outbreaks in healthcare settings, congregate settings like homeless shelters and jails, et cetera. And we know what happens is that it's not only the patients that are affected, which is tragic enough, but it's also the staff that are affected, and the staff are then quarantined or they have to be excluded, and then that really limits our ability to serve our patients at a time when we need every staff person that we can get. So you get a double whammy every time, and that's just something else to keep in mind of, is that non-vaccinated staff are high risk. We definitely want to protect them, but we also want to make sure that they're not going to be vectors for outbreaks, and that, I think, is the rationale for the steps that are being taken to get that new health officer order in place. There's low chances of return to blueprints, lockdowns, mask mandates per se, the field hospitals, even the military staff deployments that we had at some of our healthcare facilities and skilled nursing facilities. I don't see any of that happening this time around. No one's even discussing this stuff. And so I don't think that this surge is going to look like the winter surge in terms of its numbers or in terms of the number of resources that are going to get deployed for it. And so basically, I think everybody just needs to know that, the resources that we have to work with are very different now, and we need to plan a little bit differently for this time around. I do think it's time to reinforce all of those layers of protection. I really love this mental model that we've been sharing. And it really it serves just a lot of useful purposes, just in terms of educating the general public and educating ourselves and our employees. But basically, these layers of protection, if you strengthen each one, you really do get a lot of benefit. And so just to remind everyone, you've probably seen this slide. Sometimes it's called the reason model, and it was invented even before COVID came along. Sometimes it's called the Swiss cheese model, but it basically just shows you that, every layer helps to protect by covering up the imperfections of the other layers. And so whenever you layer things together, we know masks are not perfect. We know hand hygiene may not be perfect. We know that vaccines are not perfect, ventilation. But when you put them all together, then you really do have a good defense against the pandemic. And I think that, for better or for worse, some of these layers have gotten a little bit looser. And that's allowed this Delta to really take advantage. One major gap being the vaccinations. But the masking, there's a lot less masking going on in the general public. Perhaps even in healthcare, we're not doing the masking as well as we could be. And so all of these layers need to get tightened up again, especially during this time of surge. And I think that it's worth your while to message about this, insofar as your organization is doing surge planning, is to say that there's no new tools in our toolkit. These are all tools we've all known about. We just need to use them to our advantage as best as we can. Speaking of vaccines, here's just what our plot looks like. As you can see, there's a real plateau towards the end there, and we've got 56% of our residents that are 12 and older. So 56% of our eligible folks are vaccinated. That's a little disappointing. We really wish it was closer to 70 to 80%. And some counties in California, believe it or not, are up in the 90s with this statistic, meaning that most of their folks are extremely well vaccinated. But we have room to improve. But we do need to keep targeting certain regions, just based on things like how many vulnerable people there are in terms of their comorbidities. Are there populations that have denser housing and they're not going to be able to socially isolate, things like that. We've been trying to do that all along, but it's going to become more important again as we think about, which are the more high risk groups. They're going to be the people that are densely congregated, that are having to do essential jobs. They're not going to be able to take time off of work, so they're going to be exposed to a lot of other people, and then also those who are not vaccinated. So we can almost predict who is going to suffer from this surge, just knowing what we've learned from prior surges. So why aren't folks getting vaccinated? This was a really interesting article. I'll just put this in here almost as an FYI. But basically, it's not that they're all anti-vaxxers. This is an article from The Atlantic. And the title of the article is "America is Getting Unvaccinated People All Wrong," because they're not all anti-vaxxers. And they actually go through and talk to doctors that have really done a lot of education related to vaccines. And they're just saying really basic stuff, like not everyone has access to the internet. Not everyone has access to a physician who can answer their questions about basic side effects. Not everyone has time off from work to go get a vaccine, or childcare or transportation to facilitate that appointment. And so it's really basic things that if we can just help meet those needs, we would actually be able to meet more people. And there's not like this monolithic population of people that are rabidly anti-vaccination. And so I think it was just a really good article that really opened my eyes to, a lot of the nuances to the unvaccinated population. But nonetheless, I urge you to read it. I put a link in for it on this slide. And hopefully you can be part of the messaging, and have these conversations at each encounter. Whenever you have a clinical encounter, just point blank ask people, are you vaccinated? If you're not, what can we do to convince you? What are you worried about? Sometimes it's really basic stuff. Like they didn't know what the common side effects were. They've read only, the headlines are only like, oh, blood clots or myocarditis, and those are very rare side effects, but non-clinicians obviously wouldn't be able to appreciate that those are very rare side effects. So it's just really basic information and education that can go a long way, especially coming from a credible resource like a clinician at the bedside. All right, let me move forward and just talk a little bit about surge planning, only to just reiterate that we should all be doing preparedness planning. Regardless of if you're working on the outpatient side, if you're working in administration, we all just need to ramp up. I think all healthcare facilities just need to get ready and brace for impact. We're hoping it's a gentle impact. We anticipate that it will be gentler than the winter, but it may still cause some real pain points for those who are not prepared. We had a really robust discussion with our hospitals last week. So I just want to send my appreciation to David Bocci and to all of our hospital partners for really facilitating some of those discussions. And really the areas of concern that they shared were very common to all of them, meaning that, staffing is at pretty low levels compared to where it should be. Space is pretty limited and at a premium related to high volumes. Supplies such as PPE and medications are really things that they're concerned about. The surveillance testing is something that they're all at a different point about doing that. And some of them have actually, passed the vaccination kind of almost as a requirement or a strong recommendation in some cases, while others haven't gone that far. But basically, it was a nice discussion to have. I just think that this is really something that, as a whole community, we need to start having, because I do see that there's going to be just an impact on every single clinical encounter for the next 2 months. Just because you're going to have a lot more people walking through your front door with asymptomatic infection, or even with symptomatic infection. They're going to be much more infectious than the good old plain old COVID infections that we've been used to in the past. And so you absolutely need to have all of your layers of protection in place in order to protect your workforce and to make sure that your areas are safe. All right, so let's talk about the new state health order, because I think that that's exactly what the point of this is a lot this when this first came out, the headline was the state is mandating vaccinations. And that's actually not what the fine print says. So hopefully you'll get a chance to look at it. I've given you links on this slide set to the order, and then I've also basically copied and pasted the entire order. And I'm not going to go through all of it. This slide basically summarizes the order. But what the state has done, and this is actually in conjunction, it's a joint order between the state and the feds. And basically, this is a new policy for healthcare workers. It's going to take effect on August 9th, and then healthcare facilities will have until August 23rd to come into full compliance. They've divided healthcare settings into 3 different categories. And here the categories are the orange box, and then the other 2 categories are this blue box and this blue box. If you're in the orange box, general acute care hospitals, skilled nursing facilities, or intermediate care facilities, then your requirements for this order are to verify vaccinations among your staff. And they give you very, very good lists of what you can verify using, like what documents will count towards verification. Then you have to do masking for your unvaccinated staff, and it has to be medical grade. So they can't use cloth masks anymore. They have to use either surgical or N95 if they have access to patients. And then the non-vaccinated staff need to get tested twice a week. Okay, so it's not really a vaccine mandate, as you can tell, although obviously getting tested twice a week is no fun at all. And so we really think that's going to nudge a lot of your non-vaccinated staff to just throw up their hands and say, you know what, this is not worth the hassle. I'm just going to go get a vaccine. And that's totally fine too. For everyone else, it's basically very similar, except it's 1 time a week testing. And you still have to do medical grade masking for non-vaccinated folks. Okay, so hopefully that's clear. I really wish the state had not divided things up into 3 different buckets like this. I wish they would have just said, you know what, everybody needs to do the same thing, and everybody needs to do twice a week testing, and that's that, or once a week testing, whatever. I wish that they would have made it, one standard for everyone, but that's not what they did. And this is what they did. So just figure out where your facility fits into these 3 categories. And then you'll be able to figure out what you're required to do. And then there's a few slides in here that are basically exactly copy pasted from the memo. And this is a slide about how to verify vaccinations. This is a slide about masking requirements. And this is a slide about the actual testing requirements. You could do either antigen testing or PCR, again, once a week or twice a week, depending on how high risk they consider your facility. Okay. So the benefits of this order, well, this is going to actually give us evidence-based risk stratification. So, people that are not vaccinated are higher risk, and we're really going to be able to do surveillance on them a little bit closer, which I think is absolutely the right thing to do, because those are the folks that we're worried will get sick or will bring COVID in and spread it. So it strengthens our early warning systems for outbreak detection, and we know masking works, and this basically strengthens our ability to do masking as another layer of protection. And again, it's not a vaccine mandate, but it is going to nudge some people to get their vaccine. There are some drawbacks, and again, I don't want to belabor this, because I think under a very quick schedule, the state is doing the best that they can. But obviously, there's confusions about the categories. what about pre-hospital workers or home healthcare workers? Those are actually not in any of those lists that I shared. What if a staff member works at two different places that fall into two different categories? In terms of the vaccine verification, I'm still not clear who does the verifying. Is that HR? Is that, does the hospital have to keep that on record, or do they just have to sign off on saying that they've done it? Again, it's probably buried in the fine print or coming out later. The state is basically coming out with a lot of FAQs, and so they're adding to this order just in the form of FAQs and AFLs. And so a lot of these questions are good questions that we can elevate for you if you have them, and hopefully you'll get good answers from the state. Who covers the costs of testing? Well, assuming that your employees have coverage, their plan should cover the cost of testing. And how do the tests get relayed between patients, the staff who are tested, us here at Public Health, and obviously you as employers and the state in terms of the state databases. What are the mechanisms of enforcement? What are the consequences of non-compliance? What about breakthrough infections? And when do we go to mandatory vaccinations? All left unanswered by this health officer order. So I can understand that there's a lot of confusion and frankly frustration. We're doing the best that we can. And hopefully in the next couple of weeks, we will have much more clarity about all of these questions and whatever else you have questions about. Any questions so far about that one? I know that that's a big order and that it really was just a lot to absorb this week. But I think it's important, and I really think that this is the right way to go, just in order to keep our facilities safer. So hopefully you can incorporate this into your processes in the spirit in which it's meant.
Hey, Dr. Vohra, Lance Granum, RNIP here. I wanted to touch base with you a little bit on people that aren't vaccinating in our facility. About 80% of them have already had COVID, and they're feeling that they're as immune. And with that Cleveland Clinic study that just came out, according to that study, they are just as immune. So this is their concern, and they want to know why the government isn't letting them do antibody tests regularly to avoid the vaccine that they don't want.
Yeah, that's a great question. I sympathize with them. I really do believe that, a prior COVID infection does grant some level of immunity. Unfortunately, there's not enough robust science to know exactly who is good after an infection and who is going to be vulnerable to a reinfection. And until we figure that out, either with antibody testing or some other testing, again, it just goes back to passing the buck on surveillance. It's like we have to do risk stratification somehow. It seems like the easiest way to do risk stratification right now, before the antibody science is worked out, is just to ask, have you had your vaccine or not? Because that's something that's, relatively easy to track down and show as proof. With antibody studies, some people's antibodies wane. And so even after a COVID infection, they may be left vulnerable to a new infection. Then again, some people's antibodies don't wane and they may be good. Also, antibodies are not the only star in the immune galaxy. You have memory cells, you have helper T cells, you have a lot of other things going on. And so we may be looking at the wrong part of the body to really determine who's good in terms of immunity. It may not even be related to antibodies themselves. They may just be a marker for some other immune mechanism that actually confers the immunity. The immune system is super complicated. So I think that's kind of where the hang up is in terms of doing some of these antibody studies and rendering people, giving them a stamp of approval based on that. I absolutely sympathize with them, because when you look at, reinfections, there's just not a lot of them. You're absolutely right. And I asked Dr. Kok Kumar and some of the other folks on my team to really do a deep dive on this question, because I think it's going to come up more and more. Is, people are going to say, I've had COVID, I'm very protected. Why are you making me go through all of this? Unfortunately, right now, this is the mandate. So we're held to this. This is the standard of the law as it's written right now. So it's like, even, regardless of what my personal opinion is, this is the mandate that we have to follow and that everyone is held to. But hopefully more science will come out and they'll keep refining this. And that's exactly what we should expect, is that this will be refined as more studies are done.
Yeah, I agree. I agree that that's a huge issue. I just don't know how to convince these people to vaccinate when they feel that somebody's profiting off of them taking
Yeah,
the
they don't
vaccine
have to
as opposed
vaccinate.
to it being legitimate.
There's nothing in this memo says that people have to vaccinate. If they have a strongly held belief or a religious belief, that's totally cool. They just have to get tested once or twice a week and then do the masking. All right, let's move on. In terms of speaking of testing, this is a great segue. So another really subtle thing that happened over the last week is that the CDC kind of changed the testing recommendation for if you're a close contact and you're vaccinated, you now should go ahead and get tested. So before the CDC said, if you've had a close contact, you could just do a directed quarantine. And if you're not symptomatic at all, you don't need to get tested. You just graduate out of that quarantine after 10 days. Well, now they're saying, go ahead and get tested at 3 to 5 days. And that's because this Delta variant is showing up in asymptomatic people that are vaccinated. And so I think the CDC is interpreting that to mean, vaccinated people can be carriers of Delta variant and help spread it. And so we need to exclude those people if they have positive tests. Again, it's unpublished data, which is causing a lot of consternation, but it's in there. Another qualification here is that the CDC doesn't write the law. They just make recommendations. So take that as you will, but it's worth reading. I've made a link to the CDC, and I've also made a link to the best story that I could find about this, which unfortunately is Yahoo News. So it's always a bad sign when Yahoo News is what's driving our recommendations at public health, but here we are. I just couldn't find a better easy to read resource about this. And even the CDC language about this it's different depending on which page you look at. So they haven't updated all of their web pages to reflect this. It's just on this one site that is in the bottom right here. But multiple, Washington Post, New York Times, a lot of different major publications have covered this. It's just, this is the best explanation that I've seen about this new subtle change in CDC recommendations. All right, lastly, speaking of CDC recommendations, they also made a not so subtle reversal in terms of their masking recommendation, and CDPH very quickly followed. And basically the bottom line is everyone should be wearing a mask indoors. Vaccinated, non-vaccinated, doesn't matter, just wear a mask indoors at all times. That may not matter to you if you're working in a clinical setting because we've never taken off our masks. But for those of us who are working in office settings and in administrative settings, I think we were getting a little bit complacent and not using masks indoors. And all of that has to go back to masking immediately. So please, please, please message about this very strongly. The debate is over. We got to put the masks back on until this surge is over. And that just means, in all settings, outside of your house, you just need to be having a mask on when you're indoors. And also a different guidance was also reversed, which has to do with the K through 12 schools. And they basically recommended, regardless of vaccination status, all of the kids, teachers, staff at K through 12 schools also need to mask up. So again, two major reversals for the CDC. They're really trying to, message this change in policy as best as they can. And honestly, they're taking some hits for credibility, but I don't blame them. I think this Delta is just throwing so many curveballs that they're actually trying to react as best as they can based on the trends that they're seeing. And they tried to qualify it by saying that, in high transmission areas, well, guess what? All of California is a high transmission area. The only kind of low transmission areas that would be able to escape this masking recommendation would be like in the Northeast states, where they have really high rates of vaccination, and they're not seeing the surging Delta numbers that the rest of the country is seeing. And I think I have that on this map. So as you can see here, they're basically showing, the blue represents higher case rates, and the lighter areas represent lower case rates and higher vaccination rates. And so you can see here, California is mostly blue. At the time that this was made, Fresno somehow was less in the lower case rate category, but we've since come up above that. So we're now solidly one of the blue counties. that the CDC is sharing out. So just FYI, basically the whole country, especially parts of the less vaccinated southern states, are really seeing just a massive uptick in the number of cases, but California is not spared either. All right, this is local data, and this is very concerning as well. This is showing you that younger ages are now driving our case rate rises. So I know this is a little bit hard to read, and I apologize. The very top left is young people from 0 to 29 years. Then the middle graph is middle-aged folks from 30 to 60 years, and the bottom graph is older folks from 60 to 80 years. So what you can see here is all these lines are rising, except in older folks. Older folks are not driving the case rates anymore. They're actually falling below the county average, and they're actually stabilizing or coming down, whereas young people are going up and middle-aged folks are going up as well. So just to show you, young people are driving the case rate. We actually put out a press release from the county yesterday based on this graphic, which just shows that what you see here is two crossing lines. One is the trend of people over 65, which is the blue line, and one is the trend of people under 18, which is the green line. And you can see at the very end, which is the latest data that we have, the green line is now way above the blue line, meaning that younger aged people are coming to the emergency department and the hospitals more than 65 and older patients whenever it comes to COVID symptoms. This is a pretty rough estimate because it's based on syndromic surveillance, and syndromic surveillance is based on symptom reporting, and it's really just it's almost like a very rough AI, and it basically just finds all of these different symptoms that are being populated in different EMRs, and then just gives us a very rough estimate. But it is an early warning tool for public health threats. We're using this to look for heat-related illnesses, influenza illnesses, and here COVID-related illnesses. But it's just interesting that we are seeing this pattern of younger and younger people having higher case rates, which is shown on this slide, and hospital and ED visits, which is shown in this slide. What does that mean? Well, basically the Delta variant affects kids and young adults. We're seeing summer camps all over the US and here in Fresno County that are experiencing outbreaks. And this, like I said, is really causing us to look at schools very carefully because we think that this is a premonition for what schools are going to have to deal with. So again, prior testing is required for overnight camps, but obviously if the person tests positive, they should not even get in the car to go to the camp to go do their camp. However, what we're seeing is people that tested negative, and then by the time they show up to the camp 24 to 72 hours later, they're either symptomatic or they get retested and they're positive. And that actually gives us a lot of concern, is that, with new case rates going up very quickly, camps are basically seeding a lot of kids that are going to go on to seed their schools in Fresno County, as well as in other counties across the state. And that we're just setting ourselves up for having a really rough beginning to the school year. So we're trying to get our camps to be as safe as possible as well, in anticipation of the school year, which is going to start in mid-August. And if you're a parent that's sending kids to camp, you have absolutely every right to ask, what are their safety precautions, and are the folks vaccinated? Don't be shy, because I think that really sends a signal that you do care about safety. And all of these camps, they're having variability in terms of their vaccination rates, just put it that way. All right, what are we doing in terms of planning and progress? Well, we continue to stress the importance of vaccinations, as you can tell, as well as every other layer of the pandemic response. We are engaging our partners, as we've always done, including employers, the different industries and businesses, our primary care clinics and FQHCs, our schools, our community-based organizations and faith-based groups. We're trying to promote education and incentives for vaccine uptake. And we're basically going to help, support / clarify anything related to the health officer order, which, starting on August 9th, will require the surgical masking at least, and testing non-vaccinated staff at least weekly, if not more. School-based masking, COVID testing, and safety plans will all be critical. We're really just trying to educate all our partners about that stuff. And then again, just, looking at camp outbreaks as a dress rehearsal for what to expect in the school year. One more thing that's come through our radar, which we just want to share with you, is that, as you see increased numbers of patients, you're going to see people that could really benefit from monoclonal antibodies. So we haven't talked about monoclonal antibodies in a long time, but they haven't gone away, and they've actually been found to be pretty useful in preventing hospitalizations whenever a person is high risk and they just freshly have been diagnosed with COVID in the first few days of their infection. Monoclonal antibody infection might actually prevent them from having to be admitted. So please think about that. We've actually updated our monoclonal antibody guidance. Dr. Zweifler has done a very nice job tracking down all of the clinics around town that are offering this. And that guidance is actually found online, and maybe Sim can drop that in the chat. But basically that guidance is out. And then this is actually just a list of different articles that talk about just different pilot programs around the country where people have actually done mobile units. They've actually just taken the show on the road because they understand that, not all facilities are able to offer monoclonal antibody infusions. It does require, a dedicated space, dedicated staff, really just a lot of resource investment. And then you may not get patients coming all around the clock every day. So it just seems like a mobile unit makes a lot of sense to go meet patients where they are and to go all over the county or the city in order to perform this procedure. And so that's basically what some people have done. I would love to see that done here. In the meantime, we do have several clinics around town that are happy to see patients and get referrals. So please look at our monoclonal antibody guidance. If you start to see these patients and you're like, oh, you know what? This person could really benefit from monoclonal antibodies and maybe we could prevent a hospitalization for them. Please look at that guidance and please reach out so that we can help get this tool in our toolbox used to its fullest potential. Just a couple of webinars I wanted to share. Dr. Murphy really very kindly invited me to this one. It's the HEAL program, and they're basically doing a series of 3 different talks next week, August 3rd, 4th, and 5th, related to COVID vaccine hesitancy and education trying to overcome that hesitancy. So I'll actually be speaking on the first day on August 3rd, but you can actually register for all 3 days at that link at the very top. And they're all happening from August 3rd to 5th from 10 to 11 a.m. So I'm looking forward to that. Thank you, Dr. Murphy. I really look forward to a really great dialogue related to vaccine hesitation and vaccine education efforts. Another webinar that's being organized by UCSF. It's actually very similar. It's about the Delta variant and post-vaccination infections, also known as breakthrough infections. And basically, this is another set of experts based at UCSF who are going to be talking just in a virtual town hall format. This is going to be on August 4th. So a lot of good stuff coming up next week. Hopefully you can join some of these webinars and continue your educational journey. Dr. Al Sagbini sent us this slide, and I just made this a weekly mystery. So this is a 36-year-old male. He visited Huntington Lake, so he was up in the foothills, and he basically recalls only mosquito bites. However, this is also an area where ticks are endemic, and his labs show that he has transaminitis, low platelets, and a peripheral blood smear shows these beautiful spirochetes. So we'll leave this as a mystery for you to solve, and hopefully do some dust off some of your infectious disease textbooks and see if you can figure out what this is. And we will bring you the answer next week once we document what some of the lab testing shows. I think Dr. Al is helping to facilitate getting some specialized testing from the CDC. But this is an actual live case of spirochetemia here in our county that was probably picked up during this trip to the foothills. And again, this is a good segue to just talk about climate change, because we know vector-borne diseases are going to increase, along with a lot of other illnesses related to extreme weather events, heat stress, air quality, water quality issues, and food supply issues. And that's the reason that we created a work group, which is forming right now. We're calling it C6, Central California Climate Change Clinical Collaboration. And we'd love to have you join us. So contact us if you're interested. This is to just talk about research and surveillance, education and advocacy, and then obviously preparedness and mitigation for a lot of the climate health effects that we know are going to impact all of our populations here in Central California. So I'm pretty excited about this. I'm scared and excited because I think this is the pandemic to come. Even while we're not done with this pandemic, we really do need to be thinking about climate change and all of the effects that it's going to have. And so I'm excited to be part of this work group that's forming. And we hope that other folks will also lend their skills and their talents and their passion to this topic. All right, that's all that I have. Thank you all very much. And I think what we'll do is take questions if you have them and go from there. Let me stop my share here and we'll go through the chat. But otherwise, if you have any questions, go ahead and unmute yourself. Oh, wow. Talkative group on the chat today. All right. Let me see here. Yvonne made a good point about homeless resources. Yeah, I don't know exactly what your question was, Yvonne, but I did mention homeless resources as part of the surge planning. Super important, and it is being done. We've got a really good team here in place at the county level. Obviously, we're working with all of our congregate settings, including homeless shelters, to make sure that they understand the risk of the surge to them, that they are actually they fall under this new order as well as a congregate setting, and so they will need to do the testing of their non-vaccinated staff and the surgical masking in all of their shelters and things like that as well. So I don't know if that was your question, but yeah, if you have any other suggestions about how we can support our homeless population, we'd love to hear it.
Hey, Dr. Vohra, Aaron from Community Medical Centers. Real quick question for you. Hey,
Sure.
So as we see kind of this next round of COVID take shape and we kind of go back into response mode, is the county planning on doing any public messaging to folks for, testing, vaccination? Vaccination, of course, but do we set up testing, community-based testing again? All that stuff. Is that coming back?
So the state definitely wants to do that. They just sent out a survey today saying, what do you need to ramp up your testing? So I think that they are thinking about those things, and I absolutely agree with you. I think we do need to offer more testing capacity so that people that are at risk can get tested and get the results in a timely fashion. So thank you for bringing that up. That's something that we do want to be working on. But if there's something that you can think of that we can start right away, even outside of the state resources, then we'd be certainly happy to support you with that.
You bet. Thanks, Dr. Vohra, as always.
Thanks, Aaron. Sure.
Dr. Vohra, this is Yvonne. I'm wondering
Hi,
about PUI follow-ups. A lot of the work that we were doing, the contracts with the county ended in June. Is that something that you see the county continuing?
Yeah, I mean, are you talking about contact tracing or is that the kind of follow-up?
Contact tracing,
Yeah, our medical investigation team will try to do that. But I have to tell you, when the numbers go up, basically we have finite resources and capacity here at Public Health. And so it just leads to delays. And we understand that that's an unfortunate casualty of a surge. It's something we experienced in both of the prior surges, is that, we weren't able to reach people for days and days. And sometimes they ran out of their quarantine or whatever, or, they were no longer symptomatic by the time we were able to call them to do the contact tracing. And so it's really something that behooves all of us to know about. And at the time that the swab is done, as I've said before, I mean, I said this many months ago, the contact tracing should be done at the time of the swab. So if you're worried enough to test someone, then basically have them jot down who are their close contacts. Who did you talk to without a mask on, in close proximity in the last 48 hours, and just jot down a list of those folks so that you at least know in your mind whenever your test comes back positive, these are the folks that are most high risk that I need to reach out to. So that's kind of what I recommend for contact tracing, is that it really helps to do it at the time of the swab. Otherwise, because the swabs, that gets delayed, So then it takes 24 to 48 to sometimes 72 hours to get the COVID test back. And then by the time you get the test back and process that and then call the patient back, it may add on a few more days to that. And so everything gets more delayed. And then, and that basically just leads to inefficiencies and then, rapid spread before that patient actually gets the information that they need to keep themselves and their families safe. So it's a good point. It's something that we're unfortunately going to see again, but insofar as we can prevent it, I think it's going to start with good education and taking a really good history at the time of the swab.
So, Dr. Vohra, let me just repeat back what I'm hearing. Regardless of whether we know they're positive or not, if we're swabbing them, we should be contact tracing as soon as the swab or as soon as possible.
Yeah, only because the first step of contact tracing is getting that list, right? So, you don't have to call everybody on that list, but at least generating that list, I think that's a smart move, because then, that person can at least have that on file, and then you can very quickly go through. And if they do come back positive, then you have that whole list of people to call right away or text right away.
Yeah.
And if you don't have that list, then you have to start from scratch. And then if they come back negative, you just ignore that list, So that's basically, how I would do it. That's kind of,
Okay.
like whenever you have a classroom environment, that's exactly what we do. But that's because the classroom environment is very stable, and so you already know, okay, who all is in that class. We have a list of those families. We contact those families right away. And basically the contact tracing has already kind of been, started even before the case happened, just because you kept a line list of the cohort. I know that that's harder to do in a workplace setting, but again, that's why it's important to do it at the time of the swab.
Okay, thank you.
Thank you.
Hi, Dr. Vohra. Rick Lembo. How are you?
Hi, Rick. Good.
Quick question for you. In regard to vaccine status and the definition of an exposure, has the definition of an exposure changed now that there's a vaccine status?
Good question. And no. Exposure is still close contact within 6 feet for more than 15 minutes.
Masked or unmasked?
Doesn't matter.
Vaccinated or not? Doesn't matter.
Doesn't matter. No problem. Now, what does matter is if masks were being worn, then you don't need to send people home. And so obviously in the healthcare setting, everyone's wearing masks. And that's why we allow people to stay working while the close contact directed quarantine period is being employed. But that's, those are nuances that, again, the definition of a close contact doesn't change. It's just our approach to the close contact changes depending on if they had a mask on or not.
Okay. But vaccine status does not change.
Not really. Before we were saying if the person was vaccinated, that you could just do their directed quarantine and then just graduate them out without a test done. Now the CDC is recommending doing a test on day 3 or 5, just to make sure that they're not having a positive test, even if they're vaccinated and asymptomatic. So that was what that slide was that I shared about the CDC testing change.
Right. And they can still continue to work if they're asymptomatic while they're pending their results, just like before.
Yes, they can. Yes, they can. And that's important. That's a great question, because you're going to be testing some of your employees twice a week. And so the question comes up, like, do we have to send them off of work twice a week? No. They can keep working until they test positive, and then at that time you send them home. But that whole twice a week business, they can just keep working as usual. And if they test negative, they test negative. But if they test positive, you have to send them home right away.
Right. Thank you.
Sure. All right. Just looking at a couple more of the chat questions. Is the PCP office to test once per week? I believe so, but you can go back and check the memo. Can we bill the employee's insurance? Yes, you can. But talk to your HR folks. But again, it's just like if the employee was symptomatic and they had to get a COVID test because of symptoms, who would you bill? So it's the same. It's kind of the same thing. but we've been told that health plans have to cover the cost of testing, regardless of whether it's done for symptoms or no symptoms, or screening or testing or whatnot. Are we to test anytime during the day or at the beginning of their shift? Yeah, that's a good question. I'm not really sure how to answer that one. I think it's going to be hard to test them all at the beginning of their shift or before their shift starts. So you're going to have to, do some logistical planning to see how you can get that accomplished. You may have to do it in the middle of a shift. The key to testing is just to do it frequently. So, again, that 2 times a week, just get into the rhythm of doing it. And chances are, the vast majority of them are going to be negative, hopefully, if all of the other layers of protection are being put in place. But for the ones that you do see positive, you're going to have a very rapid way to pull them off of shift and then do the contact tracing right away. All right. What is the quarantine period for a close contact that is tested negative, and also for the ones that test positive? Well, the ones that test positive, that's pretty easy. They start their 10-day clock. So basically, if they're asymptomatic and they test positive, then they have to be off for 10 days after the test was done. If they test negative, then the close contact quarantine period is currently 10 days of directed quarantine, meaning that they can still go to work, provided that they're wearing the masks, etc. But they have to be monitored for 10 days for symptoms, and just very closely watched to make sure that they don't have any symptoms onset. And then they also should get an exit test to make sure that they're negative. Has there been any update on the California QR codes for individuals vaccinated outside the state or at a federal facility? I haven't heard that one. Sorry. I don't know if that's a VA thing, Holly, or I'm not sure what the QR codes refer to. There is a state database called CARE, and that database keeps track of everyone who's been vaccinated within the state of California. People that have been vaccinated outside the state, I'm really not sure how to track those folks down unless they have their cards or some other medical documentation from their provider. But that's a good question. I actually skipped through a slide that has all of the different documentation options, but I can pull it up again. And that slide is basically just good to know about. It's one of the FYI slides. So here it is. This is the vaccine verification options slide. And so these are the 6 ways that you can verify vaccinations in your staff. And that's included in the slide set. Okay. Including something called the WHO yellow card. I don't think that has to do with soccer. All right, so I'll include that in your, that's included in your slide set also. Can we do a molecular test instead of PCRs? Yes, you can. Okay, Dr. Ganga has a diagnosis of leptospirosis. Okay, thank you for sharing that. We will let you know next week what the answer is. Keep those answers coming on the weekly mystery. Okay, let me go up to is the employer required to pay for weekly testing of staff who are unvaccinated? Again, it has to do with their health plan. So I would say go to their health plan and make sure you work it out with them, because that's what we've been told. But we'll get you the information about who's going to pay for the weekly testing as we get it. I don't have any further information about that yet. What is the evidence that monoclonal antibodies work against Delta? So monoclonal antibodies are thought to work pretty well against Delta. I haven't been able to do a deep dive into that literature, but that's why they're coming back as something that to just regard as an option, is because the current thinking is that the monoclonal antibodies, as long as you're using the combination products that are now recommended, they will work against the Delta variant. is the Binax Now test still available for providers to pick up? That's a great question. We do have Binax Now tests. So please reach out to us and we'll work with you to get you those antigen tests. I'm not sure what our exact inventory is. I'll have to talk to our supply folks in our EMS division, but we'll definitely try to work with you. And if we need to request those supplies from the state, now is the time to do it. So thank you for reminding me. If you need PPE, if you need anything, masks, etc., please send us an email with your needs. The more details you provide, the better, just in terms of numbers and where you need them and when you need them. And then we can actually elevate all of those requests to the Mohawk, which again, during surge times, those supply lines become really important. So start working on your own, do your own homework to get your own supply lines tightened up. But then if you do need supplies for PPE testing, etc., then certainly reach out to us, email us, and we can try to get you connected with our EMS division.
Hey, Dr. Vohra, they're closing the testing site at Reedley College. Is there a way we could not do that?
Yeah, thank you for that. From what I understand, it's going down to a couple times a week. Is that not right?
All I've been told I'm sorry. All I've been told is that it's closing, and I was told that it wasn't going to be open. So that's all I've heard locally.
We'll note that because what we heard was that it was going down to 2 days a week. That's an OptumServe site, and OptumServe is contracted with the state. They've still got 3 sites here in Fresno County, but they've really demobilized to where they're just offering several days a week, just because the numbers were doing so well. So now that the numbers are rising again, I absolutely agree with you. We need to bring the testing back up to the demand that we're going to anticipate and really get people tested. And then obviously with this health officer order coming online in August, that's actually going to increase the demand quite a bit. So we're aware of that, and we're going to try to work with OptumServe or some other company to make sure that there's testing available for the general population, as well as for any staff that might need it.
Thank you, sir.
Sure. People are sharing places where you can get testing done. So hopefully everyone's following along in the chat. Thank you, Colleen.
Dr.
Let's
Vohra,
see,
this is
Care
Dr.
Center.
Henry. All of our sites are providing testing. So we have a large facility in Reedley that provide testing.
Where, I'm sorry, who is this? And what site is that?
Yeah, this is Ganga from United Health.
Oh, hi. Okay, great.
Yeah.
Okay, so United Health Site Center in Reedley.
All our sites are providing testing, and we will expanding it with the need. And there's a large facility in Reedley that would be providing adequate
Perfect.
testing for Reedley.
Okay, great. Sounds good. Thank you. Oh, and Sim just dropped our site, our testing sites link, so you can check that as well. And hopefully that will be current for which sites are offering testing. All right, and Sonia has one last comment about, what is the number of deaths in people that are vaccinated versus non-vaccinated? That's a great question. It really is paralleling the number of hospitalizations, meaning that, vaccinated individuals are just not really having the fatal outcomes that non-vaccinated individuals are. The few ones that we've had here in our county had other comorbidities. Like I remember one that was a renal transplant patient. They were on multiple immunocompromising drugs. And so it's not a huge surprise that they really didn't have the benefit from the vaccine that a normal person would have, just because of all of their immunocompromising drugs. And they also had renal failure. And so, there's usually multiple comorbidities, even in vaccinated patients, that kind of tip them towards having a more tragic outcome. For the vast majority of new deaths that we're seeing, though, they're all unvaccinated. And that's what my vital statistics team is sharing with us, is that, all of the death certificates that we're processing now, the vast majority, like more than 90%, are in non-vaccinated individuals. So it's real. I mean, these vaccines really are protective. And it's unfortunate that we don't have more of our population vaccinated, but hopefully we can share the facts on the ground and convince more people It's going to take one at a time, and it's going to take all of us to have those awkward conversations with our patients and with our colleagues for that matter. But we need to do it because it's really important to protect ourselves and our community. All right, we are over time, and I'm sure we will have lots more updates next week. So we'll just plan to do another update with everyone next week. The recording will be shared with everybody, and the slide set will be shared with everybody. In the meantime, have a great, safe afternoon and the rest of your week. And hopefully we'll see everybody next week. Thank you so much. Take care.
Thank you.
Bye.